वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा पद्मपत्रविशालाक्षी पद्मकेसरवर्णिनी नित्यं पद्मालयां देवी सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
Good evening, everyone. Welcome to our fourth session of the ISCI Physics webinar series. Today, we'll start with cardiac MRI. We've already discussed basic MRI sequences in the last 3 talks. If any one of y'all have missed it, y'all can go to our ISCI website, and in the Pearls of Physics, you'll find all the previous webinars uploaded. You all can go through them. So today's talk is on basics of cardiac MRI sequences by Dr. Podyavan. Podyavan is consultant cardiothoracic radiologist at KMCH Coimbatore, and he's one of our active executive committee members and a physics nerd. So he will be talking on this today. The session will be moderated by Dr. Sanjaya Vishwamitra, who's the chairman of the our ISCI organization. He is head of department of Satya Sai Institute in Bangalore. He's also a physics expert. So both of them will take you through this topic today. Over to you, Podyavan, for your talk.
Thank you, Richa. Okay. So we are back in the ISCI Physics webinar series. We have had 3 sessions so far on basic physics, and the last session was the all-important session on K-space and parallel imaging. So now we are slightly going forward. This session 4, what we are going to cover is the basic sequences in cardiac MR. So we will just see the sequences that we commonly use in cardiac MR, and the objectives of this talk is to give you an overview of the hardware requirements for doing a cardiac MR, what are the common sequences that are used while performing a cardiac MR, the basic physics behind these sequences. If you have gone through the previous talks, the physics remains the same for all these sequences. There'll be just some minor modifications here and there. So we'll just go through them and also see what these modifications result in image quality and how to get better quality images by playing around with these sequences. So coming to hardware. So a minimum of 1.5 Tesla MR system with a powerful gradient with a slew rate of at least 150 is desirable for doing a cardiac MR. Theoretically speaking, lesser field strength magnet can also be used to do a cardiac MR, but for everyday practice, for clinical practice, we see that a minimum of 1.5 Tesla gives you good quality images. So you have a 1.5 Tesla system. Do you need a 3 Tesla system? So as you all know, like in neuroimaging, a 3 Tesla system is always better than a 1.5 Tesla system because it gives a good quality, a better quality scan every time. But is it the same with cardiac imaging also? So it's not the case, so because with the 3 Tesla system, there are both pros as well as cons of doing a cardiac MR with a 3 Tesla system. So the advantage of having a 1.5 Tesla system is that a 1.5 Tesla system has less susceptibility effects, less field inhomogeneities, so you get better quality cine images. And also because of the lesser field strength, the ECG quality that you get from inside the gantry are also better compared to a 3 Tesla system, where the higher field strength interferes with your ECG tracings. The advantage of a 3 Tesla system is that so since the field strength is high, there are more protons that are available for image formation. Hence, a better signal to noise ratio is attainable with the 3 Tesla system, and the scan times also become shorter in a 3T. So because of the better SNR, especially the post-contrast perfusion images, the delayed enhancement images have a much better contrast and signal to noise ratio compared to a 1.5 Tesla system. And whether 1.5 Tesla or a 3 Tesla system, the presence of parallel imaging capability in that system like SENS, GRAPPA, or SMASH will always be helpful in cut-shorting the duration of scan. Coming to the coils, you can use either a routine quadrature body coil or a dedicated surface cardiac coil. Body coil is most commonly used because of its easy availability and a good signal to noise ratio. However, because it is a quadrature coil, the RF deposition is along a wide area of the patient. So the specific absorption rate is pretty high in a body coil compared to a cardiac coil, which is a surface coil. So it is placed on the chest wall closer to the heart. So it gives you a better signal to noise ratio and a low RF deposition. However, a dedicated cardiac surface coil will be expensive. So most of the centers still are capable of doing good quality scans with a body coil. And whatever coil you have, it should have at least 8 coil elements or 8 channels for it to enable parallel imaging. Then the next important point is that whatever system you have should have ECG gating capability, because all the cardiac scans are ECG gated. Pulse gating is preferable if it is present, because sometimes because of the magnetic field or some other reason, you don't get good quality ECG tracings, or the R wave is not sharp enough to trigger the scan. So in these cases, what you can do is you can use pulse gating, which is nothing but peripheral pulse meter, which is attached to the finger of the patient, and the scans are triggered using the peripheral pulse. Coming to ECG leads, the graphite leads are always preferred. They are a little bit expensive compared to your routine ECG leads, but it is worth the price. This is because the metallic leads produces a lot of artifacts, especially in a 3 Tesla system. It will produce a lot of magnetic field inhomogeneities around it, and will be a lot of artifacts, and the risk of magnetization and projectile formation is extremely minimal, but still there is a risk. Coming to the extra hardware that are necessary while you're doing a cardiac MR. So a respiratory gating balloon, which is a small air-filled balloon which is tied to the epigastric region of the patient, so that it provides you the tracing of the respiratory movements, diaphragmatic movements of the patient, and helps in respiratory gating. An MR compatible infusion pump or a contrast pump is also necessary, especially if you're planning on doing perfusion imaging, stress tests, and angio. If you are just limited to doing a viability scan, then an infusion pump or a contrast pump might not be necessary, but it's still good to have. An MR compatible monitor with BP, SpO2, and ECG is also necessary when you're doing adenosine stress imaging, as well as dobutamine stress imaging, to monitor the vitals of the patient. And the last is an MR compatible anesthetic equipment. Again, It is not a compulsion that it's not also economically possible for every system to have an MR compatible anesthetic equipment, but it really helps when you have a really uncooperative patient or a sick patient who's under general anesthesia. In these kind of situations, doing a cardiac MR becomes much easier if you have an MR compatible anesthetic equipment. Coming to ECG. So why is ECG calibration very important for ECG gating is that the magnetic field from the magnet, either a 1.5 Tesla or a 3 Tesla system, induces certain changes in the ECG. So this is called as magneto-hydrodynamic effect, which is nothing but a flowing blood, which is a good conductor of electricity in a high static magnetic field, induces electric current within it, which can contaminate the electrical signal of the ECG. So because of this effect, the ECG that we often see in the monitor when the patient is inside the gantry can have a tall
Hi, good evening. We seem to have lost the connection to Dr. Pudiyavan. Please stay online. We will be back shortly. We're still having some trouble. Please continue to remain online. We're still checking for our connection. Dr. Padiyavan is just checking his connection. Please remain online. Yeah, we can see you, Dr. Padiyavan.
Yeah, sir. Sorry, sir. I think my internet connection suddenly dropped.
It's okay.
So
It's okay.
So I'm not sure when I dropped out.
You can start from ECG calibration. And
ECG. Okay. Yeah. Okay. So I was talking about ECG calibration, why it is important, because of the phenomenon called as magnetohydrodynamic effect. So what happens is that blood, which is a good conductor of electricity, so it is a conducting material. So when there is flow of a conducting material in a high static magnetic field, it induces electric current in the conducting material. So in this case, in blood, there is some voltage potentials that are generated, which contaminates the electrical signal that is coming from the heart, which is the ECG signal. So what happens because of this is that you get a tall T wave, which can confuse the system from correctly interpreting an R wave for ECG gating. An ST segment elevation or depression can happen, which can mimic an ischemia, ongoing ischemia, and R wave inversion. So for proper gating, what we need is a sharp and a tall R wave. And so the ECG calibration is done both outside as well as inside the gantry. So what this does is that the system adapts the ECG signal both within the gantry and outside the gantry, so that you get a good quality ECG tracing, which helps in proper ECG gating. So we use mostly retrospective gating for cine and phase contrast images, whereas for morphological imaging, we use mostly prospective gating. So these are the sequences that are used in cardiac MR. This is the most common sequences that are used in cardiac MR. There are many more sequences. So we will just go through the common sequences first. The survey and the frequency scout imaging, the black blood, which is nothing but the spin echo imaging, the white blood, which is nothing but the gradient echo images. The cine sequences can use either an SSFP or a steady state free precision sequence, or a spoiled gradient echo sequence. Black blood images also have morphological black blood images, which consists of double or a triple inversion sequence, which we'll go in detail later. And there are post-contrast images like dynamic perfusion sequences, the delayed enhancement sequences, which are used for myocardial fibrosis, and flow images to quantify flow using phase contrast images. And last but not least, we have the different parametric mapping techniques like T1, T2, and T2 star mapping. So in this session, we will just cover the initial basic sequences, and in the subsequent sessions, then we will go into the post contrast and the phase contrast sequences. Coming to the survey image, the survey image is the same survey that we use in any other body part. So it's a morphological image covering the entire area for us to plan subsequent sequences. So one thing that is done extra in cardiac imaging is the process called shimming. So shimming is nothing but a process by which you obtain a homogeneous magnetic field. The magnetic field is the most homogeneous at the center of the gantry. So whenever we image a part, it is always advisable to have the imaging structure at the center of the gantry. So suppose we are doing a brain MRI, we place the patient such that the head is at the center of the gantry. So if we do a knee MRI or an ankle MR, so we place the patient such that the knee or the ankle is at the center of the gantry. But the problem with cardiac imaging is that the heart is not placed at in the center of the body. So it is slightly, its axis is slightly tilted towards the left side, and it is very difficult for us to position the patient such that the heart is at the center of the gantry. So we do something called as shimming, which produces a homogeneous magnetic field in the desired area using the gradient coils. So this this inhomogeneity is more pronounced in a 3 Tesla system than a 1.5 Tesla system, and that's the reason we get good quality cine images in 1.5 Tesla, whereas there are more artifacts in 3 Tesla. But this shimming is manual shimming as we speak. Is not available with all the vendors. Some vendors provide manual shimming, some vendors doesn't provide them. So there are other ways of getting good quality images in using the gradient echo sequence. So one such sequence is called the frequency scout, which is nothing but a routine gradient echo image, but which is acquired at a single slice with different frequency offsets. So here you can see a set of multiple gradient echo images, which are obtained at the same level, at the mid cavity level in short axis view. However, each image is obtained with a different frequency offset. So what we obtain from this here is that, so we visually look at these images and select a single image at which there is least artifacts and the greatest contrast between the LV cavity and the myocardium. And if you see here, so these couple of images seem to have the least artifacts and the greatest contrast between the cavity and the myocardium. So we select this particular frequency offset to image the subsequent gradient echo sequences. So by this method, so we can bring down the amount of inhomogeneity artifacts that are present in the gradient echo images. Coming to the first set of sequences are the black blood images. So black blood images are nothing but routine spin echo sequence. So we saw what is a spin echo sequence. So it consists of a 90-degree pulse, which is followed by a 180-degree refocusing pulse, which gives rise to a echo or signal. And in case of cardiac imaging, the TR of the sequence, that is the time between one 90-degree pulse and the next 90-degree pulse, is 1 RR interval. But however, the problem with using a routine spin echo sequence is that it takes multiple 90-degree RF pulses to generate a single image. So this means that you'll have to image the patient over multiple RR intervals to obtain a single image. So this is overcome by something called as a single shot fast spin echo sequence. So fast spin echo sequence is nothing but a multi-echo sequence. So we spoke about what is a multi-echo sequence. So multi-echo sequence is nothing but one 90-degree RF pulse is followed by a train of multiple 180-degree refocusing pulses. So there is one 90-degree pulse, and this is followed by multiple 180-degree pulses. And each 180-degree pulse will produce one echo or MR signal, which fills the a single line in the K space. So what happens here is that within a single RR interval, we are able to fill multiple lines in the K space, which is sufficient for one image formation. So a single shot fast spin echo can produce an image in a single RR interval. So you need not image the patient over multiple RR intervals. The problem with multiple RR intervals is that then the patient has to hold breath over that period of time for you to get a motion-free image. So in this one, the image is obtained in a single RR interval. So no breath holding is necessary for this particular sequence. So the reason that the spin echo sequences produces black or no signal from flowing blood is that once the 90-degree pulse is given, there is a time gap between the 90-degree pulse and the 180-degree pulse. So before the 180-degree pulse could be given, what happens is that the protons in the blood which experienced this 90-degree pulse would have already moved out of the slice before the 180-degree pulse. So those protons are not refocused by this 180-degree pulse. So moving protons, like protons in blood, produces no signal and gives rise to this black blood images, which is more common in the spin echo sequence. So the black blood images or spin echo sequences are mainly used for morphological imaging. These are resistant to field disturbances because in general, the spin echo sequences which use a 90-degree and a 180-degree pulse are resistant to magnetic field inhomogeneities. And hence, because of this, there are less artifacts due to sternal wires and prosthetic valves. However, the downside of using FSE or a fast spin echo sequence to produce a black blood pool is that there is a possibility of ghosting artifacts which can crop in. So in this patient, you can see that the nulling of the blood is not very good. So you can see some artifacts within the LV cavity here, which means that the blood is not as black as we would like it to be. So this is because of slow flow or in-plane blood flow. So the main phenomenon in spin echo sequences that produces black blood is that the blood moves out of the imaging plane between the 90-degree and the 180-degree pulse. But if the flow is very slow, or there is in-plane flow, that is flow in the direction of this imaging slice, then the blood experiences both the 90-degree and the 180-degree pulse, and hence gives off a signal which gives these artifacts. So the second set of sequences are the white blood images or gradient echo images. So in gradient echo images, as we saw, there is an RF pulse which is followed by gradient switching instead of 180-degree pulse. So there are two main differences between a spin echo black blood image and a gradient echo white blood image. The first is that we use a small flip angle rather than a 90-degree in spin echo image. So in gradient echo image, we use a very small flip angle, sometimes as low as 5 or 10 degrees instead of a 90-degree pulse in spin echo. And second, instead of a 180-degree pulse in a spin echo sequence, we use something called as a bipolar refocusing gradients to get the protons in phase together for producing the image. So when we give, because of the small flip angle and the refocusing gradients, which are also much faster, so we are able to give a lot of RF pulses, rapid RF pulses, and gradient switching can be obtained without waiting for the magnetization to come back to the main magnetic field in cases like spin echo sequence, where you give the 90-degree and 180-degree pulse and wait for the magnetization to return to its resting state. But here we don't do that. We just give rapid RF pulses and gradient switching, and this causes a very bright signal from the flowing blood. The stationary tissues, because of RF saturation, loses signal, whereas blood which is flowing shows a bright signal because of these rapid RF pulses. And this type of gradient echo images are mainly used for cine imaging because of its rapid scan time. So for cine imaging, to obtain functional data, we need to image the heart very rapidly within the cardiac cycle. So for all the cine imaging, we use the gradient echo sequences. The downside of gradient echo sequences is that it is susceptible to field inhomogeneity because it uses gradient switching for producing images. And so it is very important to use either shimming or use frequency scouts to determine the correct frequency offset before we do a gradient echo sequence. Coming to cine sequences, so there are two main sequences that are used to produce cine images like this. One is the SSFP sequence, or a steady state free precession sequence, and the second is the spoiled gradient echo sequence. So in SSFP sequence, what happens is that each RR interval corresponds to one TR, and the phase shift that occurs, the dephasing that occurs, is extremely minimal at the end of one TR interval, and hence it produces a very high signal intensity image. And also the inherent contrast of this SSFP sequence produces a high myocardium to blood pool contrast because of the inflow effect of blood and the T1 and T2 contrast of the myocardium. So both these, coupled with the very minimal dephasing of protons that happens in an SSFP sequence, produces a very bright signal from the flowing blood and a low signal from the stationary myocardium. So this produces a sequence like this, where you can see that the blood is bright and the myocardium is low signal. The second type of sequence is the spoiled gradient echo sequence, which again uses a very short TR with dephasing of the transverse magnetization using a spoiler gradient. So this also again suppresses signal from stationary tissues, whereas the rapid dephasing of the transverse magnetization doesn't happen in blood that is flowing. And the contrast in the spoiled gradient echo is dependent on the T1 and T2 star weightage of the tissue. Among these two, which sequence to use? We usually prefer using an SSFP sequence, especially in a 1.5 Tesla system, because SSFP sequences are more prone for in magnetic field homogeneity related artifacts. So in a 1.5 Tesla system, an SSFP sequence gives better quality images. In a 3 Tesla system, the SSFP sequences are more prone for artifacts. So if SSFP sequences produce a lot of artifacts, in spite of doing all the necessary shunning and frequency scouts, then a spoiled gradient echo sequence will give you a better quality image compared to an SSFP sequence. And as far as CINI sequences are concerned, we mostly use retrospective gating, unless the patient has severe arrhythmia, when we might switch over to a prospective gating technique, but mostly it is retrospective gating. And how this CINI sequence is produced is that the SSFP sequences produces multiple images over a cardiac cycle. So each cardiac cycle is divided into multiple phases, and one image is generated for each phase. So when all the images are run together, then we get a CINI image. So this particular CINI image consists of at least 25 to 30 images corresponding to all the parts of cardiac cycle. So when you increase this number of phases in a cardiac cycle, then the temporal resolution of the image also increases. So instead of 20, if you take 40 phases in a single cardiac cycle, then you get 40 images in a cardiac cycle, and you get a better temporal resolution. So this is how the CINI sequence works. So what happens is that you first divide each RR interval into number of phases. So for in this example, we are obtaining 30 phases from each cardiac cycle. So the RR interval is divided into 30 phases, and from each part of the cardiac cycle, an amount of imaging data is acquired, and this is repeated over multiple RR intervals to generate an image. So before we go any further, I'll just tell you about the main differences between segments and phases. So there are some systems which gives an option for changing the segments for CINI acquisition, and some systems don't give the option to change the segments, but gives an option to change the number of phases. So the main difference between segments and phases is that segments is nothing but the number of lines that are filled in the K space from a single point in cardiac cycle. So here, this RR interval is divided into 30 phases, and the first image, for example, let's say the patient has a heart rate of 60. So this one RR interval will be of 1000 milliseconds duration, that is 1 second, which is 1000 milliseconds. And we divide this RR interval into 10 phases. So each phase image has a time of around 100 milliseconds for us to acquire that particular image. So in that 100 milliseconds, if it takes 10 milliseconds to fill one line in the K space, so it will take 100 milliseconds to fill 10 lines in the K space for this particular segment. So suppose if the heart rate increases, say to 120, so each RR interval becomes 500 milliseconds, and the time available for acquisition of each phase becomes 50 milliseconds. And in that 50 milliseconds, we'll be able to fill only 5 lines of the K space. So the segments is the number of lines of K space that is filled for each image, each signal acquisition, whereas the number of phases is the number of images that are acquired across the RR interval for us to give a cine image. So increasing the number of segments will generate a larger, quicker k-space filling and a image with the lesser scan duration, provided that the heart rate is slow and there is enough space for the system to generate that many data from a single particular point in the cardiac phase to fill the multiple segments in the k-space. Coming to the parameters of a cine sequence. So the first and foremost is the number of phases. So we usually use around 24 to 30 phases for cine sequences, which is a good compromise between a much better temporal resolution and data that is needed for functional assessment. Suppose if the patient is not able to hold breath for a long time, then we can decrease the number of phases to bring down the scan duration. But keep in mind that at least 12 phases has to be there for us to get a reliable functional data in a cine sequence. The second parameter is the phase percentage, which is nothing but the percentage of phase data that is used for image reconstruction. So suppose if we have 100% of data, all the 100% data is not necessary for you to form the image. So the system can generate the image with only 2/3 of the data. So the phase percentage is often kept in between 65 to 75%. This will bring down your scan duration. Again, if you want to bring down the scan duration further in uncooperative patients or patients who can't hold breath, then you can go to up to a minimum of 50%, below which there will be poor image formation. The third is NSA, or number of signal averages. So this is nothing but the number of times you repeat the same sequences to get good signal to noise ratio from the image. So naturally, if you increase the number of signals generated, then the scan duration will also increase. And there is also a downside that because the scan duration is increasing, then there is more chances for motion related artifacts. Coming to gating, we always use retrospective gating for cine sequences. Prospective triggering can be used as only when there in cases of severe arrhythmia. We'll just talk about that later. And phase oversampling, which we have already talked about. This is done to prevent phase wrap, but it will also increase the scan duration. Coming to cine imaging in arrhythmias. So arrhythmia is one thing that is very difficult to image, especially for cine sequences. We have even gone to the extent of canceling some studies because there was just too much arrhythmia for us to get any reasonable quality scan. So there are various steps for us to get good quality images when we have arrhythmias. The first and foremost is arrhythmia rejection, which is ingrained in the system. So as you can see, this is one such system which has an option for arrhythmia rejection. So we just select it as yes. So what happens is that whenever an ventricular ectopic or an abnormal rhythm is encountered, the data that is obtained from that particular RR interval is discarded. So this will be useful only when the arrhythmia burden is extremely low. So if there is just 1 or 2 ectopics here and there, then you can use arrhythmia rejection. So the data from that particular RR interval will be discarded and you will get a good quality image with a mild increase in scan duration. But this cannot be used if the arrhythmia burden is very high, because the system will just keep on rejecting all the RR intervals and you won't get any data for image reconstruction. The second is reducing the number of phases. So as I told you, the number of phases determines the temporal resolution of the image. The number of phases can be reduced up to a point for us to reduce the scan duration. So reducing the scan duration helps in reducing the incidence of arrhythmias also. So the incidence of arrhythmia will also come down if the scan duration drops from 10 seconds to say 5 seconds. So what we can do is, in cases of arrhythmia, we can try to reduce the number of phases so that the breath hold duration is not prolonged too much. So the third is RR window percentage. So this is nothing but the percentage of RR window variation that is acceptable from beat to beat. So suppose this RR window percentage here, the percentage is kept at 20 to 30. So this can be increased to say 30 to 40 or 40 to 50, meaning that the system will accept the variation in RR interval up to 20 to 30% from one beat to other beat. So this increasing the RR window percentage will result in cardiac blurring, but at the same time you'll be able to get diagnostic quality images. The next option is to reduce the number of segments per cycle. So this is what I was talking about when I said the difference between segments and phases. So in this, what happens is that we give a number of segments per cycle according to the shortest RR interval that is encountered. So here is the average cycle length that is given here. So we can select the number of segments which corresponds to the lowest RR interval that is encountered during the arrhythmia, so that this will produce good quality images in spite of arrhythmia, though it will increase the scan duration a little bit. The next step is to use free breathing cine sequences with respiratory gating. The main issue with arrhythmias is that it prolongs the scan duration. So most of the cine sequences are done as breath holding sequences, and if it becomes unreasonably prolonged, then the patient will not be able to hold his breath. So in these cases, what we can do is we can use these free breathing cine sequences, but definitely the contrast resolution will not be as good as doing a breath hold cine sequence, but still it will be of diagnostic quality. The other option is to use prospective triggering instead of retrospective gating. So in prospective triggering, what we do is that we determine the shortest RR interval that we are encountering in the arrhythmia and image only the initial part of the cardiac cycle to generate a cine image. But the problem with this technique is that if the RR interval is too short, then the diastolic phase in the longer RR intervals may be missed while imaging, thus giving us very spurious functional data. So this is the drawback of using a prospective triggering, especially when there is a great variation between two RR intervals. And the last is using pulse gating. So pulse gating, as I told you before, instead of an R wave triggering a scan, here the peripheral pulses trigger the scan. So you might know that not all arrhythmias are conducted to the peripheral pulses. There are a lot of electrical activity that happens in the heart, which will not be conducted as a pulse to the periphery. So when you encounter a lot of noise in the ECG, a pulse gating might be useful in many cases because many of the arrhythmias are not conducted to the pulses. So this is about the basics about the cine sequences, the various techniques of cine sequences, and what are all the basic physics that we can modify a little bit to get good quality images. The next is the black blood or the triggered black blood images. So we saw that we are able to obtain black blood images with the routine FSC or a turbo spin echo sequence itself, which is nothing but a single 90-degree pulse with a 180-degree RF pulse train. So why do you need a separate triggered black blood sequence? So we saw that the blood nulling that happens in the spin echo sequence is not foolproof. So there is a chance for a lot of artifacts, especially in heart, where there is a lot of chance for in-plane and slow moving blood. So to overcome this particular problem, we use something called as a inversion black blood sequence or a double inversion black blood sequence. So in this double inversion black blood sequence, the R wave triggers the scan, and it consists of two 180-degree pulses. So as the name implies, double inversion black blood sequence. So it consists of two 180-degree pulses before the routine spin echo sequence. So the first 180-degree pulse is a non-selective 180-degree pulse, which just inverts everything in the imaging area. So the second RF pulse is a slice selective 180-degree pulse, which is applied only to the slice that we are imaging. So the first pulse is a non-selective 180-degree pulse, which is applied to the entire heart. And the second pulse is a slice selective 180-degree pulse, which is applied only to the slice which we are imaging at this point in time. So because the slice which is to be imaged experiences two 180-degree pulses, so the slice that is to be imaged experiences two inverted pulses, and hence it is again in the direction of the main magnetic field, whereas all the other protons that are outside the slice that is to be imaged are inverted. So like any other 180-degree pulse, with time there will be the inverted magnetization will recover towards the 0 point and will start to grow towards the main magnetic field. So what we do is we apply the 90-degree pulse of the spin echo exactly at the point at which the inverted magnetization of blood reaches 0. So at this point in time, what happens is that the flowing blood will remove the blood that is present in the slice here out of the imaging slice, whereas the blood which has experienced only one 180-degree pulse and is at the null point comes into the imaging plane. So this produces a more robust nulling of signal from blood compared to a simple spin echo sequence. And hence, since this particular sequence uses two 180-degree pulse before a spin echo sequence, this is called as a double inversion recovery sequence. So these double inversion recovery sequences are used for morphological imaging. Especially they are useful for imaging in tumors and in pericardial pathologies. So here you can see this is a T1 weighted double inversion recovery sequence. This is a T2 weighted double inversion recovery sequence. And you can see that the signal from the blood is completely nulled, and there is a much better contrast between the blood pool and the myocardium. And this sequence can also be used in combination with the chemical shift based fat suppression. T1 fat suppressed image can be used to look for absolute enhancement, especially in tumors and in pericardial pathologies. And a T2 based sequence with fat suppression can be used for looking at myocardial edema. But both these sequences are basically an inversion recovery sequence. So these will be available as breath hold sequences, and the images are obtained over multiple RR intervals. So these are not gradient sequences which can be obtained in a single RR interval or as a free breathing sequence. So these are basically inversion recovery spin echo sequence. So they will require breath hold, and these are acquired over multiple RR intervals. Coming to the other type of black blood image, which is the triple inversion recovery sequence. So this is similar to the double inversion black blood sequence that we just saw. And so as the name implies, we use a third 180-degree inversion pulse only to null the signal from fat. So this is nothing but a stir image of the heart with two more extra 180-degree pulses to null the blood. So if you just see this part of the sequence, so you can see that there is a 180-degree pulse followed by a spin echo sequence. So this is a basic stir sequence which is used for nulling signal from the fat. So in addition to this, we use another two 180-degree pulses, one non-selective to the entire heart and one 180-degree to specifically to the slice which we are imaging. So this will produce the nulling of the blood. So this is called as a triple inversion recovery sequence or a stir black blood sequence, where you can see there is nulling of the blood pool as well as nulling of the fat, and you are able to see the myocardial edema much better. So this again is used for morphological imaging and to look for edema in the myocardium. And again, this sequence is also basically an inversion recovery sequence. So it will be used as a breath hold sequence over multiple RR intervals. So there are certain modifications that can be done in these double and triple inversion recovery sequences. One is that since this is the image is acquired over multiple RR intervals, in case of bradycardia, when the heart rate is very low, so the scan duration will be prolonged. So in this case, what we can do is instead of pulsing the sequence every 2 RR intervals, what we can do is we can pulse it every single RR interval. So here you can see that the no trigger period is set as 2, meaning that the non-selective and the slice selective 180 degree pulse followed by the 180 degree pulse for fat suppression are given over 2 RR intervals, so that it gives sufficient time for the 180 degree, the protons which are deflected 180 degree to regain its magnetization in the along the main magnetic field. So suppose if the heart rate is low and the RR interval is longer, so what you can do is you can pulse it every single RR interval rather than 2 RR intervals, thereby reducing the scan duration. The opposite also holds true. So example, if there is tachycardia, then 2 RR intervals will not provide sufficient time for the relaxation of the inverted pulses. So in this case, what we can do is we can pulse the sequence every 3rd or 4th R wave. So what we are doing is that we are just providing enough time for the inverted protons to regain its magnetization over a period of time. The third point is the incomplete blood pool nulling. So we use these 2 180 degree pulses to null the signal from the blood. But one thing that has to be kept in mind is that the 180 degree pulse, the slice selective 180 degree pulse that we give is always given at a greater slice thickness than the slice that is imaged. For example, this particular sequence, if you see, this is a stir image with a slice thickness of around 8 millimeter. But whereas the 180 degree slice selective black blood pulse that is given for a thickness of 20 millimeters. So a wider blood selective inversion pulse produces a more robust blood pool nulling compared to a slice thickness that is similar to the imaging plane. So always, if you are planning to increase the imaging slice thickness, then comparatively you will have to increase the slice selective 180 degree pulse thickness also, so that it produces a very good nulling of the myocardium. So these are the what the sequences that we saw today so far has been the frequency scouts, the black and white blood sequences. We saw about the cine images, the various techniques, various sequences that are used for obtaining cine images, and the various techniques that we can use to improve the quality of cine images. And we saw a few of the morphological imaging sequences like double inversion and the triple inversion recovery sequences. So we still have post-contrast sequences. We still have perfusion images which are used for myocardial perfusion assessment. We have the delayed enhancement sequences, which is the most important sequence of the cardiac MR, where we look for myocardial fibrosis. Then we have phase contrast images for flow quantification. So we will just go through them in the subsequent sessions. So the take-home message from this particular session is that know the hardware that is available with you and its limitations, so that you can effectively use the hardware. Know the physics behind the sequences. Knowing a little bit of physics behind these sequences will be very much helpful, especially for their better optimization. And there are very limited parameters that can be modified in these sequences to improve the image quality. So just try to know these parameters so that you get a better quality image. So physics is not just the theory. Knowing a little bit of physics will also help you in getting a lot of good quality images also. And thank you very much. With this, we'll conclude this session. And I'll also like to give a heads up to all you guys about the upcoming ISA annual conference, the 12th annual ISA conference, which is scheduled to be conducted as a hybrid conference. So after 2 years of online only conference, so we are moving into a hybrid mode where there will be an on-site conference in Goa, as well as an online viewership to the conference. So I think I look forward to see you all on site after a long time in Goa. And I think Sanjay sir.
Thank you, Padivan. Thank you, Padivan. That is once again a complex topic on cardiac MR and understanding the sequences. I think all of us have basically gone through the pains of trying to get good quality images. And there is no real answer to that except by doing more by yourself on the magnet. So my sincere recommendation to all of you who are listening to this particular talk and lecture is that you will understand this better if you apply it by yourself on the magnet. In other words, don't allow only the technologist to scan the patient. If you have a cooperative patient or if you have a good volunteer, please take the time to sit on the magnet, play around with all your sequences. Each vendor has a slightly different way of explaining different, different techniques in terms of how they do it. All the vendors give you multiple options to optimize your sequences as well. And usually the most commonly used robust sequences are at the top of the options, and then they give you multiple ways of trying to get different type of images. So I would say if you can go back on your scanner and you can play around with your sequences, you will automatically be able to understand and to implement the many ways of optimization that Dr. Padivan has described in his lecture today. I don't see, let me see if I have any questions. 1 second.
There's one question in the Q&A, sir.
Okay. Can you read the question out to us?
Sir, can you please explain again how spin echo helps in reducing artifacts from sternal sutures?
Okay. No, it's not that spin echo reduces artifacts from sternal sutures. It's that compared to a gradient echo sequence, the amount of artifacts that are produced by sternal sutures are much less in a spin echo sequence. That is because any conducting material, when it is placed inside a very strong magnetic field, produces its own magnetic field around its vicinity. So what happens is that there is a very big magnet in the MR machine that produces a homogeneous magnetic field. And if there is a conducting material like a sternal suture or something that is within it, so there is another secondary magnetic field that is produced surrounding it, which throws all the protons haywire. So the signal from that particular area is poorly, it's very poor, and the gradient echo sequences, which depends on gradient switching for producing images, are more prone to this magnetic field inhomogeneities and susceptibility effects compared to the spin echo sequence, which uses the 90-degree and the 180-degree refocusing pulse, which are a little bit resistant to these susceptibility effects. So that's the reason that spin echo images produce a little less artifacts compared to a gradient echo sequence. This doesn't mean that the spin echo sequences doesn't produce any artifacts. It's just that compared to a gradient echo sequence, the spin echo sequences produces less artifacts because of the susceptibility effects.
Yes, thank you. Thank you, Padivan. It's important to understand susceptibility as well. There's another question here which says, can we rely on the ECG displayed on the monitor during the scan?
No, for diagnostic purposes, we can't rely on the ECG that is displayed on the monitor. So the ECG that is displayed on the monitor is purely for gating purposes. So what we look for is a tall and sharp R wave for us to gate the scan. Otherwise, for diagnostic purposes, it cannot be relayed because of the magnetohydrodynamic effect that I spoke about. There are a lot of inaccuracies that creeps into the ECG tracing because of the magnetic field, and that cannot be used for diagnostic purposes. So we have to go by the patient's symptoms and other supplementary monitoring facilities. And if the patient is uncomfortable or symptomatic, then we will have to take the patient out of the gantry and then do a proper ECG outside the gantry to look for any diagnostic quality ECG changes. Yeah,
that's absolutely correct. We don't have any other open questions. Again, I'm going to hold off, asking Pudhiyavan to explain certain things or give questions until the next talk, because I think what's important, as I mentioned, is for all of you to go back and play on your own magnet. You have to understand the terminologies on the magnet. I'll give you a very simple example. For example, one vendor might talk about spatial resolution in terms of phase and frequency. Another vendor might talk about spatial resolution in millimeters in terms of actual size of the voxel. So each vendor describes different things in a different manner. You have to understand how your vendor talks about it, particularly when you talk about segmented K-space, whether they're talking about the number of segments or the number of views per segment or lines per segment, and how it affects your temporal resolution. And it's not really complex. It sounds complex when we're describing some of these things, but the simplest thing is, if you have a sequence and if you make certain changes, and if you are shortening the time of the sequence, it's highly likely that your temporal resolution is getting worse. If on the other hand, if you're doing something in those segment boxes and you're actually lengthening the time of the sequence, it's likely that you're getting a benefit from that by making your temporal resolution better. So, so some very simple rule of thumb ways of looking at this is going to help you understand how to optimize your sequences as well. So there's one. Okay, we have some more questions. Let's see here. How is it if there is some metallic thing like a coin or pin stuck in the bowl? Will it cause any inhomogeneity? So the question basically is, if there's a foreign object and the foreign object happens to be not in the patient necessarily, but maybe has been stuck in the bore, then would you be able to see any inhomogeneity, and will that affect it, Dr. Pudhiyavan? That's the question.
It will definitely cause an inhomogeneity because as I said, it need not be in the patient on the patient, but anything within the gantry, any paramagnetic substance that is present inside the gantry will produce inhomogeneity in the magnetic field.
And the simplest way to avoid that, because you have a very expensive equipment there, simplest thing to avoid that is make sure the patient disrobes completely and changes into a proper gown, right? So that way you won't have any chance of somebody sneaking in a pencil, a hair clip or something, anything else there and ruining your magnet. Because if you have to ask the service engineer to come and fix it, that's going to be downtime on the magnet and also a cost as well. So please, just have the patient disrobe for every examination, and you will never run into problems of things being brought in inadvertently into the system. The other question here is, what is the relevance of navigated or self-navigated sequence in coronary angiography? Navigator sequence.
Okay, so I think we will be discussing about the more advanced sequences and the mapping techniques later in the series. But just to say that the 3 navigator based sequences has been available for some time for imaging the coronaries, but they are still not up to the level of using it for coronary artery disease per se. They can be used for looking at anomalous coronary origins or the proximal coronaries. But I don't think they are still at the level of imaging per se for coronary artery disease per se.
Yeah, I think Pudhiyavan has done a great job in breaking it up into these basic sequences that you heard today. And then next talk, like he mentioned, he's going to be talking more about the perfusion, delayed enhancement, and I'm sure that he's going to give a small, a couple of slides on advances like coronary artery angiography and how you need to basically navigate. You need to use navigator sequences for that as well. Breath hold sequences, non-breath hold sequences, free breathing sequences. A lot of those are slightly more advanced topics, but I think he's done a great job in terms of just discussing the basics and getting you prepared to understand the next session. I don't see any other questions. So if there are no other questions, Richa, back to you. And again, thank you, Dr. Pudhiyavan, for a wonderful lecture.
Thank you, sir.
Thank you, Pudhiyavan. Thank you, Dr. Sanjay, for your wonderful talk and for sharing your expertise with us. I would like to announce that our next session will be on phase contrast imaging. Like Pudhiyavan's covered the basics, we'll next go on to phase contrast. So that will be on 13th May. Dr. Rajesh Kannan, the secretary of the ISCI organization, will be taking the talk, and the talk will be moderated by Dr. Sanjay. After that, in June, we'll have these delayed enhancement and other sequences, advanced sequences talk. So hope to see you all in May, and we'll be sending you all the links as usual. Thank you for your time. I'll end the session for now.